We're going to have a nice panel set up for you, all talking about breast reconstruction options that we have. And because today is Breast Cancer Awareness Day, and we really want to emphasize how important that is for all women when they embark upon the breast cancer journey. So with that, and not further, I also would like to thank our organizing committee, which included Tracy Posner, well known to all of you, along with our own team at NCI, including Alexandria, including Peggy Goana, and a new member of the team. So please clap, because I want to recognize all the work that has gone into all of the. And as a special request, no lab coats, no PowerPoints. We really wanted to break any potential barriers in any of you asking any questions. We want to really for to have a very informal conversation. So therefore, as Tracy's request, no lab coats, no PowerPoints, we're just going to talk about the issues and hopefully answer a lot of your questions in a very informal setting with lots and lots of helpful
and sponsoring, and some people who I've never actually met in real life until tonight. So this is really nice to have everyone in a room together and see all of these beautiful booby crowns too. So I was asked to speak a little bit about nipple-sparing mastectomy, but before we get into that, I want to just give an overview about the different types of mastectomies that we perform as breast surgical oncologists. Nipple-sparing mastectomy is the newer type of mastectomy that we have started performing probably now over 20 years ago. It became more popular in around 2011, 2012 when Angelina Jolie underwent her nipple-sparing mastectomies for the treatment of or prevention of breast cancer with the BRCA2 genetic mutation. And before that, it really was considered something that was a little bit more taboo, and people considered it dangerous to preserve the skin of the nipple areolar complex because they thought that it would lead to cancer recurrence or new cancers developing at that site. And so prior to nipple-sparing mastectomy, we performed a lot of skin-sparing mastectomies where the nipple areolar complex was removed centrally. And most patients ended up with an elliptical type incision centrally on the breast with a straight line. And the nipple areolar complex was removed, but a majority of the envelope of the breast or the skin envelope was preserved to facilitate immediate reconstruction. And then prior to that, before skin-sparing mastectomies were deemed to be safe, patients underwent total mastectomies with removal of the majority of the skin, something called a modified radical mastectomy, where the patients would undergo a flat closure because they were deemed not eligible to have an immediate reconstruction. It wasn't thought to be safe. And so really through clinical trials and studies, it was shown that women could have, ideal aesthetic closures, and whether the patient wanted to preserve the skin envelope for an immediate reconstruction or decided not to, we saw more and more patients actually having a choice in what type of mastectomy they wanted to have done. And so now when patients come to see me and we talk about mastectomy, I kind of start the conversation out with that this is not the mastectomy that you may be thinking of in your mind, because a lot of people hear the word mastectomy and they think of their grandmother's mastectomy. And they think of a very disfiguring surgery that took a majority of the skin and left, you could see like the bones of the chest wall and the ribs, and took a majority of the muscle as well. We no longer do that. And so most patients are eligible for at least a skin-sparing mastectomy if they desire. And that means preserving the skin envelope to facilitate an immediate reconstruction with our plastic reconstructive surgeons. A nipple-sparing mastectomy refers to preserving all the skin, including the nipple areolar complex. And the way that I explain that to patients usually is picture an orange or a grapefruit, and the peel of the fruit is the skin of the breast, and everything underneath the fruit is the breast tissue. And for me at least, I usually design an incision at the inframammary fold of the breast, and so that scar is very well hidden. It's a long scar, it's not tiny, but you don't really see that scar when you're looking head on at the patient because it's underneath the breast. And we create that incision and then lift up the skin of the breast and dissect all of the breast tissue from underneath that skin. And it's a delicate operation because if you go too thin and too close to the skin, then you risk compromising the blood flow to the skin into the nipple areolar complex. But if you go too thick, then you risk leaving breast tissue behind. And so you need to have the right skin thickness and the right patient to be able to perform this operation. And so patients can meet criteria for a nipple-sparing mastectomy through two ways. One is from the oncologic perspective, and that's me. I'm deciding if it's safe from a cancer perspective to save the skin of the nipple areolar complex. And and the other is from the plastic surgeon's perspective, will it look good? And so from my standpoint, I will perform a nipple-sparing mastectomy, obviously, if there's no tumor at the nipple. Ideally, we would like a 1 centimeter margin from the nipple to the site of the tumor, and even more if possible. But if looking at the imaging, there's no calcifications that are suspicious leading up to the nipple, there's no enhancement seen on MRI leading up to the nipple, then it's usually safe from an oncologic perspective. Now, if the patient shows up with bloody nipple discharge related to her breast cancer, we are not offering nipple-sparing mastectomy. Or if there's skin involvement and you have to take a big portion of the skin, or the patient has what's called an inflammatory breast cancer, or a majority of the skin is involved as well, then they are not a candidate. That would not be a safe procedure. At the time of surgery, if the patient is deemed to be a safe candidate, I take a margin of tissue from just under the nipple areolar complex, we call it the nipple margin. And if that tissue doesn't show any cancer, then the patient can safely save the nipple areolar complex. If that tissue shows cancer in it, then we usually advise the patient to have the nipple removed at a later time with the plastic surgeon. And as our plastic surgeons will probably get into very shortly, from their perspective, they want to make sure that the patient isn't too ptotic, meaning that the nipple doesn't point down towards the ground, because in patients like that, when you try to do a nipple-sparing mastectomy, sometimes the nipple is not in the correct position. And so sometimes we have to stage a patient if they're eligible to do that, where we lift the nipple up with a mastopexy procedure, and then go in and do the nipple-sparing mastectomy a couple months later. Other things to note is with nipple-sparing mastectomies, while we can give someone a really nice aesthetic result, and sometimes it's even hard to tell that that patient had a mastectomy, most of the time the patients are losing a lot of sensation to the skin and to the nipple areolar complex. The sensory nerve endings that lead up to the nipple get cut during that surgery, and until recently, we weren't even thinking about trying to re-sensitize those nipples. But Dr. Medina may talk to you a little bit about, lately we have in certain candidates been trying to reinnervate those nipples by using a cadaver graft, a nerve graft, and have been somewhat successful in certain patients. And so there is a lot of promise to the future of nipple-sparing mastectomies and trying to give more sensation to patients, because this is actually an area that's very important for patients. Not every patient, but a lot of patients, when you tell them they're going to lose sensation to the skin and the nipple, that's a shock to them. And it matters more to some patients than other patients. And so it's really nice to be able to offer this operation to patients now. It gives them just one other option. It's not for everyone, but for patients who are ideal candidates because their tumor is far from the nipple and the breast is the right shape and size, it can really give them the best cosmetic result where it's hard to tell they had a mastectomy.
You have 4 minutes and
I speak fast. Well, a lot of patients will come in and they want nipple-sparing mastectomy. There are patients that are not interested in reconstruction at all. And so what's in a little bit more trend these days is an aesthetic flat closure. So for patients who really want no implant, they don't want to deal with reconstruction, they want to feel free and not have to deal with the reconstruction, because the reconstructive process can be an actual real process with multiple surgeries, and it has some perioperative complication risk. Some patients don't heal well, they develop infections, they have to have multiple surgeries, and when that happens, it's not fun. And so there are many patients who opt to not deal with that, or maybe they've had implants and things didn't work out with it and they decide later on to go flat. And so we work hand in hand with our plastic reconstructive surgeons, even on the patients that don't have implants placed, where they want an aesthetic flat closure, so a majority of the skin is removed, the chest wall is closed flat, and patients are very happy with that result as well. And then lastly, if you're not a candidate for a nipple-sparing mastectomy, but you want a nipple areolar complex, there are many ways to reconstruct a nipple that our plastic surgeons are going to talk about. And we actually have a 3D tattoo artist. I don't know if Suzanne Mo is in our audience tonight, but she's excellent. And she creates 3D nipple areolar complex tattoos that look so real that you have to feel them to determine whether or not they're real. And it's really unbelievable what she can do. You can look at her Instagram page and see her results, and they look even better in real life. And so these patients that have 3D nipple areolar complex reconstructions, it's flat, but looks raised. And then there are other ways that our plastic surgeons actually make a new raised nipple and then tattoo it. And so even if you can't save your nipple, there are other options to make it look really, really good. And it's really nice to be able to see pictures and visualize what to expect after surgery, and our plastic surgeons do that for our patients as well. So with our varied audience here today, I'm sure there's one of everything. There's someone who has an aesthetic flat closure, there's someone who's had a skin sparing, someone who's had a nipple sparing, someone who's had implants that decided to take their implants out. And so every case is very different. It's a very personalized decision, but the nice thing is that patients have more choice than ever in the matter. It used to be that patients really had no choice when it came to reconstruction, and now there's so many ways to reconstruct the breast and so many different types of mastectomy that we perform. Thank you.
Versus implant-based reconstruction. Thank you, Dr. Medina.
Thank you much, Dr. Mendez. Thank you, Tracy, for putting this together, and Dr. Mendez for putting this together. I always tell patients when they first come to see us that it's a little bit of drinking from the fire hose when you come see us, particularly for a patient who's just gotten a diagnosis of breast cancer. They're trying to absorb what does that mean for them long term with treatment. Am I going to have radiation? Am I going to have chemo? And then you start to get to the breast, and I warn a lot of patients that in many ways the breast reconstruction is the most complicated part of this process. So the most important part is to get you cancer free, but the part that you will deal with, for potentially a long time is going to be the breast reconstruction. And there are a couple of general pathways to start this off, and then things start to narrow down into two kind of main tracks. The first is the use of your body's own tissues, all of your own tissues. These are usually abdominally based. The most advanced version of that you'll hear these days is called the DEEP flap, the DIUP flap. And that's essentially a transplant of tissue off of your abdominal wall and a re-implantation under a microscope to blood vessels in the chest. That's probably the most sophisticated operation we do, and it makes an incredible breast in most cases, but its consequences to the abdomen can be a little bit undersold. And so some patients do very well with that operation. Some patients will have consequences to their abdominal wall for that they will deal with later operations. And in a small handful of cases, that operation will lead to total failure. And then you come back to this conversation about implants or hybrid operations that use implants and other tissue from the body. The best flap patients are patients that have a little bit of a tummy because you need to make a breast out of it. Patients that are potentially going to end up with radiation. Radiation patients down the line tend to do better with flaps. And then like I said, the flap itself makes an excellent breast. The abdominal site is what you end up kind of dealing with, and there are ways that we can minimize consequences for that. We will try and spare nerves when we do these operations. We'll try and reconnect nerves when we try and do these operations. And then there's also operations in which you don't have to use such a sophisticated transplant. So for a patient that has one-sided breast reconstruction, has a larger breast on the other side, doesn't want to consider implants, the old-fashioned pedicle tram operation, in which this muscle and this tissue is maintained together and brought up, actually has excellent results. And for one-sided breasts, it has, in general, similar results with abdominal wall function to the DEEP flap. We don't do double trams for people because that would take both of your abdominal muscles, so you'd have no abs left. I think that is a very hostile operation to the abdomen, but the DEEP flap sort of mitigates that risk. Once you get away from flaps, implant-based breast reconstruction in some ways is easier, faster recoveries, but it has a couple of major asterisks to it. Number one, now you're getting a breast implant. And a breast implant has consequences of itself. It's a man-made object. That implant is not going to, for most patients, last their entire lifetime. That will eventually be replaced. A lot of the implants we use these days are what are called sort of cohesive gel implants. These are the most modern silicone implants in which that silicone is a solid gel. The two latest generations by two of the manufacturers, actually I think you can say all of it, but the two latest generations, you can take a scissor and cut the implant in half, hold it, and the gel doesn't come out of it. So these are not like your implants that you heard in the 1990s where they would rupture, you had free silicone leaving through the body, you had these tunnels. And those are, even when we encounter them these days, are nightmares when we find old ruptured implants. The modern silicone gel, when they rupture, their biggest problem is that sometimes it's hard to tell that they've ruptured. Sometimes the breast will sort of contract and become hard, and that's a sign that, okay, we need to get an ultrasound or an MRI. We look at your implant, and we decide that whether or not it needs to be replaced. But the truth about having a breast implant is for most patients, you have a more or less 100% chance of a separate operation to replace that. That being said, implant replacements tend to be well-tolerated operations. They tend to be outpatient operations. They tend not to be drains. We always joke here because Dr. Daragopian, who many of you may have known, has patients that are well into their 80s, and they will come to me with a ruptured breast implant. So you just want to list why you just take everything out, do a flat closure. You don't have to ever think about this again. People look at me like I have two heads. They all say, I want my last set of implants. So not to trivialize return to the operating room, but for most people that's a tolerable thing. That's the number one problem with implants. There are a couple of things that go in a media cycle. One of them is very important, and one of them we don't know how to address it entirely. So there are some very rare cancers associated with implants, with textured implants. So rough-shelled implants are sort of in the process of being taken off the market these days. They're associated with a lymphoma that happens in potentially as little as 1 in 3,000 patients. The numbers vary between 1 in 15,000 to 1 in 3,000 in published reports. But every time they look at it, that number seems to go up a little bit. So we don't use anything that's textured in this institution. We don't use any textured implants. We don't use any textured expanders, and we recommend either monitoring or exchange for patients that come to us with a textured implant. That's a well-documented problem. There's a very rare, well-documented skin cancer type called squamous cell that has been found in some people's capsules. And there's somewhere in the low teens to 20s so far been identified out of the millions of implants that have been placed. We don't know entirely what to make of that. It seems to be something that's what's called a foreign body reaction. We see this in patients that have had burns, for example, and then 20 years later they come with one of these types of cancers. I suspect that as you start to look for this more, you're going to see this with joint implants, you're going to see this with pacemakers. It's extremely rare, but it seems to be a reaction to a foreign body and inflammation. That one I tell patients is not as clinically relevant as the lymphoma stuff. The lymphoma stuff is absolutely relevant. And then the last thing comes in this sort of nebulous category of implant-associated illnesses. And I think that those are real entities, but they're also very rare, and they come in a very mixed bag of symptoms. So we have some patients that had a breast implant placed, and 3 or 4 months later, they have hives. They have all of these different laboratory values. Their joints hurt. They have these unexplained fevers. And you remove the implant, that stuff goes away. And those seem to be those are the slam dunk implant-associated illnesses. Why do they exist? We don't know. They don't seem to be a purely silicone-related issue because they haven't been documented in saline implants, so it must be something with the shell. It's probably something with a manufacturer, with a batch, with a lot. Those things are very hard to figure out. Patients that have had implants in for 20 years and then they have some of these symptoms, those are very hard to tell. I take implants out for those patients that want to take those out, but some of those patients feel better and some don't. I would say that's a 50% or less success rate for people that have had implants for many years and then they have seen some of these other things that are probably not related to the implant, but maybe, and you take the implant out of the equation. So I think for most patients, implants do very well, but like I said, everything has its cost. So flaps have a cost to their abdomen. They have a possible total failure. Implants, you're going to have to exchange them. There are some other sort of categories that we come across. We talk to patients that are much less frequently utilized. So one is an all fat grafted breast. The fat grafted breast can be done. It can make a breast mount. It doesn't have the same shape as an implant. It doesn't have the same shape as a flap. Those require multiple operations. So I tell some of my patients, you're going to have 4, 5, 6 operations to make a breast with the fat grafting, or you can take your chances with the implant over the next 30 years for exchanges for people that are just purely worried about having operations in the future. Worried about silicone safety, foreign bodies, those become different conversations, and then fat grafting is an option if you're not a flap candidate or if you have a flap failure. And then in our radiated patients, flaps tend to be the best option for them where any complication comes up with radiation. The implant becomes chronically contracted, there's a problem with the skin, there's all sorts of things that prop up with radiation. I would say that Dr. Treiser and I would both agree that the biggest bane of our existence is radiation. Outside of that, most other things tend to go well. The issues with implants tend to be all up front, so you worry about infection rates and healing the skin. We have outstanding mastectomy surgeons. Our complications for pure skin problems are very, very low. Our infection problems, they run, I warn patients, you have about a 4% chance that this will be taken out and removed for a period of 3 to 6 months before it can be replaced. That's the number one concern of ours. What is our loss of reconstruction rate? And here we run, the 4-ish%. So if you look in published rates in the literature, that number can run as high as 17%. We're an experienced center, we're a high volume center, but that's still, for anything you do in surgery, a 5% complication rate is a very high rate. So that's the risk factor there that we go through. Once you're a month out from surgery, your body's kind of created a capsule around this device, you've healed, the skin looks good, it's kind of rare to have those complications after that. So that's all kind of an upfront cost with the implants. After that, implants tend to be a much easier route out. We tend to utilize a lot of tissue expanders here. The reason for that is that there's definitely an increased complication rate in going directly to an implant on the day of mastectomy. There's a higher rate of problems with the nipple, and there's a slightly higher rate of infections. It's because you're putting in a fixed volume into somebody, and the mastectomy, no matter how good the mastectomy is traumatic to the skin. The blood vessels that run from the chest wall, they go straight to the skin. You're going to remove that with the breast. That skin circulation is not normal. It has to be given a chance for the capillary system to sort of recover. And what a tissue expander does in the modern era is it buys you time. It's not like 30 years ago where we did a modified radical mastectomy, we took a bunch of skin, we put a tissue expander in there, we spent 3 months trying to stretch the skin back out. Today, the expander is there as a lifeboat, your skin is going to be there. We're underfilling that to let that skin recover, and then we're quickly coming up to volume. So usually within a month, most people are at the volume that they're going to be at. Am I running over? I think
Thank you for segueing into my topic. It works very well. I want to thank you, Tracy and Dr. Mendez, for having us here today. Everyone can hear me okay?
Yeah.
Perfect. So the first topic that I was tasked with discussing is a flat closure. And I think when I first started doing breast reconstruction, I used to sit down with all of my patients and talk to them about the different options for reconstruction. And I would start the conversation with, you don't have to have reconstruction. It is not a requirement for mastectomy or cancer treatment to have breast reconstruction. And then I would discuss a flat closure. Now when I really discuss this with my patients, I kind of use flat closure as a reconstructive option rather than a choice for not having reconstruction. And why is that? I think actually, as the aesthetic flat closures become more popular and more patients are electing for it, we have seen that it is really a reconstructive procedure that can help patients experience the life fulfillment after mastectomy that they want, even without having a breast present. What is an aesthetic flat closure? It's when a mastectomy is performed, and instead of putting a device in, such as a tissue expander or a breast implant, or your own tissue to recreate a breast, we close the breast in a flat manner that is aesthetic and contoured to the chest wall. It has many advantages and disadvantages. Perhaps the biggest disadvantage is there is no breast there. For some patients, that's desirable, so it's not a disadvantage. For other patients, they elect to have the flat closure for reasons that I'll discuss in a little bit, but then they can obtain a breast prosthesis later on, so when they're out in clothes and wearing a bra, it can look like they have a breast. Why would somebody who would wear a breast prosthetic want that? One of the biggest advantages to a flat closure, I think, is, as Dr. Medina said, there's a 4% risk of reconstructive failure. But if you include other little things that can happen, maybe a little take back to fix a skin issue or an infection requiring antibiotics, then that rate goes a little bit up in terms of a complication. So having a flat closure for sure has the lowest risk of reconstructive problems. Why is that? When we were in training, we had a professor who used to always say breast reconstruction is a violation of all the maxims of surgery. We're taking a compromised skin flap and then putting in a device that's putting it under tension. And that would often lead to some of the healing problems. So with an aesthetic flat closure, you don't have that. The skin usually does pretty well, it contours very nicely, and if the goals of the surgery are to have the lowest complication rate, requiring the fewest number of takebacks or subsequent surgeries, it most often accomplishes that. Patient satisfaction, I will say, in my experience, I'm sure Dr. Medina will agree, for patients who elect for it is very high, because as long as patients know what they're getting in for, they seem to sail through pretty well and be quite content with the result. And it's not to say there's complication free, I don't want to make it seem that way, but it definitely has a much lower risk profile. So in terms of aesthetic flat closure, I think it's a definite option. I discuss it with all my patients. I think it should be discussed with every patient because breast reconstruction isn't right for every patient. Additionally, there may be patient factors that might push a patient towards a flat closure. Other comorbidities, really poorly controlled diabetes, active smoking and things like that, other disease burden can all lead to the need for an aesthetic flat closure, and even the degree of skin involvement and disease progression at the time of the mastectomy can all be reasons why somebody might want to consider an aesthetic flat closure. I'm going to jump around a little bit because my next topic that I was tasked with discussing is fat grafting. Dr. Medina touched on using fat grafting as the sole method for breast reconstruction, but where fat grafting is usually most commonly used in the reconstructive process is for augmenting either usually an implant-based reconstruction, rarely an autologous or your own tissue-based reconstruction. In terms of how that is performed, at the time of a revisional procedure, oftentimes liposuction is performed in areas that are rich in fat, And this is processed and transferred and basically injected around the implant or into the breast. This has multiple advantages. The first advantage, that seems fairly obvious, is an aesthetic one. It allows us to fill areas that the implant may not fill, make contours and transition zones not as harsh, and really blend things in. Now, there are other benefits that are a little less obvious that are really important. As Dr. Medina mentioned, sometimes the bane of our existence is the radiation, and there's permanent changes that occur after radiation, and I always make it clear to all my patients, these radiation changes often are permanent. But there has been some data that's come out that has indicated that some of these radiation changes can actually be improved by fat grafting. The exact mechanism by which that happens is unclear. There are theories that it has to do with some fat stem cells being transferred and the growth factors that they release, leading to healing of the skin tissue, but it definitely can improve the skin envelope after radiation. But perhaps its best attribute is its ability to really improve the aesthetic of this. And the one thing I do tell all my patients is, whether you're getting, as Dr. Medina said, a direct implant reconstruction or tissue expander-based reconstruction, if you look at the overwhelming data on patients, the majority of patients will have at least 2 operations when it comes to the breast reconstructive process. A little bit of touch-up here and there, kind of smooth things out. It's very hard to get the perfect aesthetic at the same time as the mastectomy. So the fat grafting is often done at that time. It can't really be done at the same time as the mastectomy. And while it used, over the past 10 years, it's really become a standard practice in breast reconstruction. The next topic that I will talk about is nipple reconstruction. When I try to explain nipple reconstruction to patients, it's one of the hardest things to explain. How do you make a nipple out of the skin that's there? And thus far, the only analogy that I've really been able to use that works is it's like skin origami. We just basically fold the skin in multiple ways to create a 3-dimensional structure. And the idea is that by folding it in different ways, it gives you a 3-dimensional structure that can look like a nipple. In terms of the areola, there are different ways to do that. Some techniques involve taking a skin graft to that area. One of the negative things about skin grafts is they have different colors, but when you're doing nipple areola reconstruction, that actually plays to your advantage. By oftentimes these hyperpigment, which means the skin gets a little darker, but that's exactly what you want in a nipple areola reconstruction. So by using a skin graft there, oftentimes you can create a nice areola that looks very reasonable. I will say that one of the hardest aspects of nipple reconstruction is often we get a very nice 3-dimensional structure early on, but over time it tends to settle out and become less projected. So as Dr. Lochner mentioned, now 3-dimensional tattoos have become very popular, and I definitely think that the results are fabulous for it. They do look very realistic, and when you look at them head on, oftentimes you think there's a 3-dimensional nipple and it can look very realistic. Honestly, sometimes more realistic than the nipple that we reconstruct. I will say that I greatly respect the tattoo artists because when we were in residency, they used to make us tattoo areolas. You don't want me as your tattoo artist. I'm just gonna say that right now, okay? It's not something I specialize in. But the tattoo artists here are excellent, and you can now see there's a whole group. If you look online, this is a common topic that patients are sharing their experiences, and if you look at different professionals who do this, they do an absolutely remarkable job, and it looks very realistic. The one nice thing about the nipple areola tattooing is that the risk profile for that is very low. When we create a nipple, we don't often have an infection or lose the implant, but it is a risk. But in patients who have thin skin and who are radiated, we sometimes don't recommend doing a nipple reconstruction because the skin is just too thin, we won't get a good nipple, and there is a risk of just losing the reconstruction. And for a lot of patients, you're like at the finish line, and then all of a sudden you go back to square one, which you don't want to do. So I think the tattooing has become more common. We have patients, I'd say now, are electing more for the tattooing than for the nipple areola reconstruction. And in my experience, I've been very happy with it. It's like the last piece of the reconstructive process. I tell everybody to make sure they're happy with everything, you don't want any more adjustments, and at that point, put the nipples on. Because if you make adjustments after that, it can sometimes just not look exactly right. But the other nice thing, it's a nice little finish line to cross over to complete your breast reconstruction. I think the last thing I was tasked with talking about was what people have called scarless surgery, and I think Dr. Walker really talked about this. I think that's more of a inframammary incision that she mentioned, where we can do both the mastectomy and the breast reconstruction for a nipple-sparing mastectomy through an incision in the underside fold of the breast. The advantage to that is it's very well hidden, even though it is a long scar that will span almost the entire width of the breast. It often can be hidden very well, and you can't see it when wearing a bra or in clothes. Patients, if they're candidates for that, often do like that incision, but I do want to be clear that not everyone is a candidate for that incision. That has to be discussed both from an oncologic perspective with the breast surgeon and with the plastic surgeon. Sometimes there are oncologic reasons, location of the tumor, the size of the breast, the appearance, that don't make everyone a candidate for that incision. So while that incision is an excellent option, it's not necessarily the best option for everyone. And to kind of reiterate what both my colleagues said, breast reconstruction used to be very standardized in that everybody got more or less the same thing. Now, as technology has progressed and techniques have progressed, there are many more options, but that can become overwhelming.